everyone. Welcome. My name is Hannah. I'm the Office Coordinator for the National POLST Paradigm. Today's presentation is the Association of POLST Use with Positive Advanced Care Planning Outcomes, Insights from the West Virginia Registry. Just two quick notes before we start. The participants today will take questions during any time during their presentation, so please go ahead and type your questions in the chat box. And I am recording the presentation today, and the recording will be available at polst.org/webinars for future viewing. I'd like to briefly introduce our presenters today. Dr. Woody Moss, Professor of Medicine in the Section of Nephrology and Supportive Care at the West Virginia University School of Medicine. Woody is the founder of the West Virginia Center for End-of-Life Care. Courtney Dunithan, medical social worker, and she is the executive director of the West Virginia Center for End-of-Life Care. And lastly, Evan Falkenstine, data manager and administrator for the West Virginia E-Directive Registry. Courtney?
Thank you, Hannah, for this introduction. And thank you, everybody, for calling in today for our webinar. We are going to review insights from the West Virginia E-Directive Registry, but it can apply to any state throughout the United States. We are going to just review lessons learned from our E-Directive Registry and how it's associated with positive advanced care planning outcomes. So the Center for End-of-Life Care in West Virginia provides coordination, education, and resources so that at the end of life, West Virginians will have their wishes for care known and respected. How do we do that? We provide all the medical orders in West Virginia, provide education to healthcare professionals and community members on a continual basis. We're the sole contact agency in West Virginia for any healthcare law clarification. And we also oversee the E-Directive Registry, which has been very successful in the 7 years that it has been up and running. So we do have some disclosures to disclose today. In April 2016, the Benedum Foundation awarded the Center for End-of-Life Care a planning grant for a community palliative care initiative. Stakeholders were assembled and developed a survey that addressed the knowledge and perspectives of palliative care in West Virginia. Results were recently publicized, and they support the need for more education, advocacy, and access to palliative care in West Virginia. In the future, to wrap up this grant project, a comprehensive report will be written to implement a better palliative care program throughout West Virginia. And then also we were recently awarded a grant through the Schenck Foundation in West Virginia for the creation of psychiatric advanced directives in West Virginia, which is a huge gap in care in our state. The objectives that we will cover today are to understand that compared to advanced directives, post-use results in higher out-of-hospital deaths and in higher referral to hospice rates. You'll be able to explain how and where POST is completed by physician, APRNs, and other healthcare providers according to our E-Directive Registry data that we collect on a continual basis, and discuss how the West Virginia program provides a system-wide knowledge of patient treatment wishes and how we've developed that system.
So West Virginia has a system to improve end-of-life care, and I think we all know that when there are medical errors, we really look to the system to correct those errors. With West Virginia, what we really hope to accomplish is a system so that patients' end-of-life wishes will be known and respected, and we consider it a medical error. In fact, it's been written in the literature that it's a medical error if you don't know and respect the patient's end-of-life wishes, if they've completed advanced directives, if they've done medical orders like a POLST form. We call it POST, Physician Orders for Scope of Treatment in West Virginia, but we certainly go by the national POLST name as the name for the paradigm. So at any rate, we have a system, and we'll talk about it more, to provide patient-centered, high-quality, population-based care for patients at the end of life. And then we use processes to further that system. So, for example, we ask the surprise question, as I'm sure many of you do, regardless of what state you're in. Would you be surprised if this patient died in the next year? And if your answer is no, I would not be surprised, then that's a patient who is a candidate for a POLST form completion. As a result of identifying the patient with the surprise question, patients are offered advanced care planning, and that may include completion of advanced directives, may include completion of medical orders like a do not resuscitate order or a POLST form, or if the patient is not ready to complete any form, that's fine too, because really the goal of advanced care planning is a really good conversation in which the patient understands his or her condition better, and perhaps hopefully the family is involved in that discussion as well, and the physician or the clinician conducting the discussion learns more about the patient's values, preferences, and goals. With our registry, historically people have been able to upload their documents to our registry as well as send them into the local whether it's hospital, hospice, nursing home, submit them to the electronic health record. And then we'll also talk about where primary and specialist palliative care fits into this, because they're also part of our system too. So let's move to the next slide.
So in our palliative care initiative funded by the Benedum Foundation, these are some results that we found after our survey regarding preferences of West Virginians. 84% of West Virginians would prefer to die at home or in an inpatient hospice, and only 7% would want to die in the hospital. And then 72% of West Virginians would rather live a shorter time to avoid pain and suffering and being put on life support, which supports the use of POST and the use of palliative care throughout the continuum of care. And I think you all are probably familiar with this map, and you all have seen it. We continue to be recognized as one of 3 states that are endorsed as a mature program in the United States. We have more than 50% of the hospitals, nursing homes, hospice agencies that are utilizing our program. And we have the working e-directive registry that, like I said, is continually working on collecting data and research initiatives to back our program and to support the work that we do behind the scenes, and to educate healthcare providers to continue to use our POST form and use it in the right way.
This is a figure that shows how our system ideally works. It starts with the individual patient, and there are discussions with the patient to ensure that the patient and family understand their condition and their prognosis. As a result of the discussion, the clinician learns the patient's preferences through the shared decision-making process. And when I use the term clinician, I'm also thinking social workers, chaplains, anybody who might be involved in the discussion, in the advanced care planning discussion. With the patient's permission and agreement, a medical power of attorney form is completed 2/3 of the time or more, and we know this from registry data, our state registry data. When people do an advanced directive, they complete a combined living will and medical power of attorney form, and if they're seriously ill, they're offered a POST form. What happens then is, after that individual patient does it, perhaps it's a discussion in the physician's office, then that form is submitted to the state registry, and then those wishes should be known in the healthcare setting where the patient is next treated. And certainly we recommend that all West Virginia clinicians inquire about patients' preferences, whether they've completed advanced directives, POST forms, encourage everybody to taking care of patients, especially seriously ill patients in West Virginia, to check our e-directive registry for patients who lack capacity. And the whole goal is to make honoring a patient's preferences and orders routine. And in the continuum of care, as patients are transferred from one setting to another, we've also worked with emergency medical services, and the law now covers their checking the registry and honoring the registry in the treatment that they provide to patients. If there are errors that occur, that gives an opportunity for quality improvement. And really the whole system is designed to make sure that patients are treated according to their preferences.
So the deliverables of that system that Dr. Moss just reviewed are standardized practices, policies, regulations, and laws in West Virginia, including the West Virginia Healthcare Decisions Act. And then we also train advanced care planning facilitators throughout the year. We have timely discussions prompted by prognosis, which is that surprise question that we spoke about earlier. Would you be surprised if this patient died within the next 12 months? Specific language on the POST form, easy to read POST form. We review that during our training that we have every year to our facilitators, and we can always clarify any questions while we're in the office if a healthcare provider has a question regarding the POST form. Orders are honored throughout the system. So if you're an individual, you're completing the form with your physician, the physician can contact us if they have a question, and that can be continued to be honored throughout the system, including EMS in the field, like Dr. Moss had talked about, who are protected by West Virginia law. QI activities for continual refinement, and of course our online e-directive registry with 24/7 online access to patients' documents. Healthcare providers can sign in with a username and password and access the patient's forms immediately. And it is a kind of it's a very unique program in the sense that they can sign in with their username and password.
So before we get into the registry a little bit more, we had a couple of questions. Dr. Moss, does West Virginia have a mandate that POST forms be submitted to the registry?
No, we don't. We have an opt-in box on our POST forms, unlike Oregon, where they have a mandate that all healthcare practitioners who complete POST forms need to submit them to their state registry. West Virginians is an opt-in program.
And Courtney, could you elaborate a little bit more?
Yeah, sure. When we educate to healthcare professionals, whether it be like Dr. Moss, clinicians, social workers, physicians, APRNs, nurse practitioners, we always specify, when you're talking about the opt-in option, just explain that, if you were to be seen in one hospital that you aren't usually seen in, those physicians aren't going to have your paperwork, but with access to the registry and having your paperwork on the registry, this is how it would benefit you. And it seems that many people opt in and they don't see a problem with submitting their forms to the registry. And I think that's the important part, is the education on the opt-in box, so healthcare providers are explaining it correctly and in full to the people who are completing these forms. I think we had a question about training. How do we train our advanced care planning facilitators? So each year, the West Virginia Center for End-of-Life Care hosts a West Virginia-specific training workshop called Creating an Advanced Care Plan, where we kind of separate the POST form. We go through each section of the POST form and explain, how to complete these, what each section involves. We have live role plays that we separate the big group into smaller groups, and they can role play completing a POST form. We switch back and forth between the healthcare provider and a patient completing a POST form, and we role play that interaction. And then we also have a video that is included in that training that shows what the process is in completing advanced directives and a POST form in the healthcare setting.
And some of another question was, what specific QI activities do you do on a regular basis? A lot of those have to do with the registry, and I think the registry really closes the loop for a lot of things in this way. Patients and providers get feedback from the registry. If a physician's signature is not present or patient forgets to sign, that sort of thing, then they do get a letter from us letting them know. So we're kind of an extra verification step for the facilities that are filling out these forms. But also, we've published 3 or 4 papers based on registry data. It allows us to see, what kind of orders are being filled out, what mistakes are being made. Do people prefer DNR cards over POST forms? What settings are we seeing a lot of forms filled out from? Are there specific facilities that even aren't on board yet, and maybe we need to focus education in a different part of the state or with specific facilities? So I think the registry really provides a lot of opportunities for QI activities. All right, a little bit about the registry. Our registry accepts a wide variety of forms. It's not just a POLST registry. And there are pros and cons to the different approaches. The most popular form that we have is the combined medical power of attorney and living will. It's just a living will and a medical power of attorney combined into one form for convenience sake. We've done a lot of research that shows that POST forms are more effective in making sure that patients' wishes are honored and known than advanced directives. But I think advanced directives have some important roles to play in a registry. I think they allow, anyone over the age of 18 can be filling out a medical power of attorney form. And so it allows people to start building their habits. Both patients and providers can participate in the registry, in the Center for End-of-Life Care, in this kind of advanced care planning system much earlier. They're not waiting until they get a chronic terminal illness to then start thinking about this thing. So, we can start them thinking about it early. They can put their medical power of attorney in there, and then maybe a living will if they decide that. Then later in their life, they already know about the registry. They're already registered. So whenever they do a POST form or a DNR card, they're ready to get that submitted. And as far as, I think anytime we can increase the number of documents that we're getting, the number of documents that patients are completing, so that's the number of conversations they're having about the topic, and then the number of successful searches that are done by providers. I think that helps encourage good habits from both the patients and the providers.
So this is an example of what, yes, go ahead.
Oh yeah, I was just going to say one more thing, is that we also accept miscellaneous forms. So the registry is really broad in that, and that has some logistical problems, but it also allows us to accept religion-specific forms, or maybe something like the 5 Wishes form, which is a little more involved for people who want to really document what their wishes are, but not something that we would recommend for everyone because it's a little time intensive. But so it allows us to be open to all those different options as well. One of the advantages of our registry is that since we accept both advanced directives and medical orders, we're able to compare outcomes. Fortunately, we've worked with the State Center for Health Statistics so that we every week receive a notification of which patients have died, where they've died, and then we can enter that data into our database, and then we can see outcomes with regard to, well, if somebody did a POST form, where did they die, how long after the time that they completed the POST form did they die, how does that compare to people completing a living will or a medical power of attorney or a combined form. And this next slide shows an article that we published in the Journal of Pain and Symptom Management in 2016, and we found that patients with a POST form with a comfort measures orders were significantly more likely to have an out-of-hospital death than those who completed an advanced directive, 88% versus 56%, and the odds of an out-of-hospital death were 4 times greater for those with a POST form with comfort measures orders versus those with an advanced directive. And certainly there's been debate for probably at least 1 or 2 decades about whether or not advanced directives do they really impact end-of-life care or not. And one of the advantages of our registry is at least we're able to show that the POLST program seems to have more of an impact on end-of-life care than advanced directives. We don't, as Evan said, we don't discourage people from completing advanced directives. They are very helpful to know who the patient trusts to make decisions for him or her if they lack capacity. But really, we strongly encourage completion of POST forms for seriously ill patients so that we have more information and we have medical orders that any healthcare practitioners throughout the system, from EMS to the emergency department personnel to the inpatient personnel to people in a nursing home or hospice, can follow to respect the patient's wishes. So following up on that first study that we did, we then looked at our cancer patient population in West Virginia, and we looked at outcomes of end-of-life care for patients with advanced cancer, comparing those who had done advanced directives with those who had done POST forms. And we found the same type of pattern that cancer patients who had done POST forms were 2.3 times more likely to die outside the hospital than those who had done advanced directives. And those who had done POST forms
were more than 2.5 times more likely to die with a hospice referral than those who did not. So these are pretty striking numbers. I mean, everybody's trying to move the needle with regard to improving end-of-life care, and it's well known that cancer patients tend to have very aggressive care at the end of life. And so this article was published in the Journal of Oncology Practice and was sort of really very well received because somebody's finally beginning to show a difference. And I encourage those of you listening from other states to, this is a sort of, I don't want to use the selling point. I don't want to make it sound too commercial, but this is a reason why people might want to do a POLST form, because it has in practice resulted in better respect for their wishes and people dying in their site where they prefer to die. This is just looking at this data a little bit more. This data was a little different than the first study we did, since this is only cancer patients. It was over 2,000 cancer patients, but notice that 85% of those with the POST form died outside of the hospital, compared to 72% of them with an advanced directive, and the hospice use was 49% for those with a POST form, compared to 27% of those without a POST form, those with an advanced directive. So this clearly was a difference. And then if we look at the next slide, we can see a difference by specialty and who was completing the forms. And notice the oncologists completed 12.4% of the forms. Our palliative care physicians completed a third, and actually the primary care physicians completed the majority of them. And our next slide sort of gives us a little bit of an understanding of this data, because we see that the primary care physicians we're completing these forms. Here we go. We're completing the forms a mean of 4.2 months prior to death, compared to the palliative care physicians who were doing it, completing the forms only 2 months prior to death. And if you look at the median, the 50th percentile, again, the primary care physicians were completing the forms earlier than the oncologists. And I think the palliative care clinicians were really, seeing the patients just within the last couple of weeks of life. And if treatment limitations had not been defined, and then the palliative care physicians had a goals of care conversation and put the patient's wishes in the form of a POST form. And clearly, as we see from the previous couple of slides, the POST form and the discussion that led to the POST form completion was effective in influencing where the patient died and whether or not the patient was referred to hospice. So this was an editorial that was written about our study that was just in the Journal of Oncology Practice. And this was very gratifying, because notice the question the editorialist raised is, are physician orders for life-sustaining treatments the answer to the end-of-life care quality conundrums in cancer care? So conundrums is sort of a fancy word. It's really just been a challenge to improve end-of-life care for cancer patients. And our colleague Sandra Pedraza, who's a palliative care, or was a palliative care physician here with us at WVU Medicine, was the first author in this paper. And basically the editorialist Keith Sweats wrote that our study presented compelling results about the advantages of POLST forms over traditional advanced directives with regard to limiting aggressive care at the end of life for patients with cancer. He said the findings were impressive, and given that both out-of-hospital death and appropriate timely use of hospice services are viewed as aspirational measures of quality, these findings have valuable implications for cancer care providers. So as any of you, anywhere, whatever state you're in, as you go about talking about and trying to promote your POLST program, you can talk about the differences that the POLST program can make in terms of cancer patient care, end-of-life care for cancer patients. Patients' wishes to die outside of the hospital are more frequently honored, as best we can tell. Certainly referral to hospice seems to occur to a larger extent if patients have done POLST forms compared to advanced directives. Now, I also want to pick up the fact that the Oregon Registry has also shown these types of results with out-of-hospital death, and even more so if it's a POLST form with comfort measures orders. And then the other thing you should be aware of, the Indiana POST program, and especially their optimistic intervention in nursing homes, has shown that when they have these conversations when nurse practitioners go into nursing homes, they do advanced care planning, they complete POST forms, that this whole process is associated with a 33% decrease in hospital readmission for nursing home residents. So we are beginning in this last year or two to see some really good studies documenting the end-of-life care benefits, the respect for patients' end-of-life wishes as a result of our state POLST programs, not just in West Virginia, but also in other states that are doing research. So this is sort of an exciting thing, that we now know when people ask, well, what are the data that show that having a POLST form is any better than having the advanced directive? Now we can, now we have lots of data. Somebody wrote in on the chat function, how does one get access to the registry as a healthcare entity? So sort of available on a 24-hour day, 7-day-a-week basis. Now it's temporarily down while we're transitioning to a new provider, but it's something that will be back up, after the first of the year, and it really has been very helpful in patient care. So this is how do we think about the system, and how do the system result in better care for patients with serious illness? Well, when we're having these conversations, it's individualized, patient-centered care. When a patient makes a decision that they don't want to go back to the hospital, they're as we've shown, they're much less likely to go back to the hospital, so the hospital mortality goes down. There are fewer 30-day readmissions, and then since hospital care is the most expensive part of end-of-life care, there are lower overall costs of care. And then we've also said that there's increased earlier refer to hospice, and hospice is the thing that patients and families and surveys say, if you compare end-of-life care with hospice, end-of-life care in a nursing home, end-of-life care in a hospital, patients and families consistently report that the quality of their end-of-life care was better if they received their end-of-life care through a hospice. So they get earlier referral, they get better care according to patient reports and family reports, and the cost of the care is less because a day in hospice is maybe $180. That's the hospice per diem, I think, for the first 60 days, whereas a day in the hospital could easily be $3,000 or $4,000 in terms of hospital charges. So, Courtney, did you want to do this one?
Sure. Completing a POST form, of course, results in better care for the patient. It has patient-specific estimates of prognosis, including that surprise question that initiates the process and conversation to complete the POST form. A shared decision-making for informed consent. So you're, talking about what choices the patient wants for their care and informing them all by signing that form. Of course, you are reviewing pain and symptom management and deciding what kind of treatment you would want and what level of care you would want at the end of your life. Of course, your discussions are prompted by your prognosis and how close you are to the end of your life. Of course, you always include the family and medical power of attorney legal agent in these discussions so that everyone is well informed and they can have a part in that conversation. And we always encourage the completion of advanced directives early on, whether it be you are currently ill or you are not. We always encourage everybody to complete their advanced directives at an early age just so they're prepared for a medical emergency and that they aren't stuck in a crisis mode when they are in the hospital. And then when you're approaching the end of your life and your healthcare journey is towards the end, we are encouraging completion of the POST form so your wishes are honored throughout the system, and that's whether it be healthcare provider, continuum of care with EMS from facility to facility, and then it is put into action immediately, and then that also gives the push for a referral to hospice when you answer that surprise question. No, I wouldn't be surprised if this patient died within the next 12 months. Maybe you should initiate palliative care, and then when it gets closer, maybe 6 months closer to death, you would refer to hospice, and that always improves care and quality of life with individuals that are going through a healthcare emergency.
Right, and so thank you, these are processes of care that really are part of the system that we alluded to earlier and that Courtney just referred to. So as we think about palliative care, POLST form completion fits into palliative care, part of the process, or one of the processes. Could you advance it? My computer's not working well. So the second win of the triple win, patients are receiving the care that they want, individualized care, patient-centered care. But also the second win is that the cost of care is less, and hospital palliative care teams save money. The estimate is that for every palliative care consultation in the hospital, the direct costs are about $2,000 less. So if a hospital has a palliative care team that's doing over 1,000 consults a year, that's saving at a minimum over $2 million a year. So that really is a win. Also, and the win for the patients is their wishes are identified and respected. And if you could advance it, and then certainly the healthcare costs at the end of life for less, and we know that more is not always better with regard to healthcare because patients really say that 3/4 of patients say that at the end of life, 3/4 or more, that they don't really want to die in the hospital, that they don't want feeding tubes, various things like that. And so this whole system that we're discussing enables patients' wishes to be known and respected. Next slide.
This is one of my favorite slides as we're coming up on the 7th year anniversary of the registry beginning to receive forms. We can see we started back in October of 2010, and this is the number of forms that we're receiving every month. So this isn't cumulative. This isn't the number of forms that we have. What you can see is that not only is the number of forms we have increasing, but the rate at which it's increasing is increasing. So there's a little bit of seasonality to it. You can see people tend to submit more forms in the summer, and then as Thanksgiving and Christmas roll around, we usually see a decrease in the number of forms that we receive. This red bar is every January. And you can see we set our newest record in April of this year with over 1,600 forms received in 1 month. So I like this because I think that this chart represents kind of the market saturation or the degree to which providers and patients are getting on board with using the registry. You don't get consistent numbers that are growing like this without it becoming part of the company culture at a nursing home or at a hospital, becoming part of their policies and procedures. This chart represents healthcare providers that are completing advanced directives and sending them to the registry as a habit. It's become a thing to do, and it's nice to see that that's steadily growing over time. It's not as fast as we would like, but it is encouraging to see that with consistent education, conferences every year, with tracking down facilities that aren't participating and figuring out how we can help them and solving their problems, we're able to see continued growth, that people are buying in and they're taking the steps to make sure that things get faxed. So this chart ends at the end of October with 78,000 forms received. So we should have broken 80,000 by now, which is exciting. All right, so where we're getting forms from. 40% of our forms come from hospitals. They're the main submitters. A lot of this is, they get higher turnover rates. They just see more patients. Also, part of being a broad system is this 18% of our forms we don't know where they came from, or we're not able to track it. And part of this is that they can be sent by individual patients. They could be faxed from, the Kinko's down the street, or maybe from the bank, or wherever they work. Mom faxed the forms in from her job, kind of a thing. We also get them in the mail. Sometimes there's no return address. So we accept things from everywhere, and that means we don't always get to know where they came from. So we lose a little bit as far as the control that we have and how much we can track stuff. 16% of our forms are coming from hospices. We see a lot of hospices doing DNR cards. I mean, there are some that fill out posts, but one thing the hospices are complaining about is that their patients just aren't getting to them as soon as they'd like. So, with patients living less than 3 days, they don't always have time to fill out a post form, and instead they just opt to do a DNR card instead because it's a little bit quicker. Hospices really do a good job of taking care of their patients, and I think that once you're in hospice, the post form is helpful, but the hospices are having these conversations. They're just not documenting them as on post forms. So it's not like they're not asking the patients whether or not they'd want a feeding tube or to be on a breathing machine. They are. 8.6% of our forms come from nursing homes. We have a lot of non-healthcare organizations as well submitting forms. This could be like United Mine Workers Union. It could be PEIA, the Public Insurance Agency, offered a discount for all public employees. So, everyone at the school, a lot of them submitted advanced directives, and so these might have been from like a local high school or something like that. So a significant number of our forms are coming from outside the healthcare system. All right, so this is a description of the orders that we're seeing in Section A and B of the post form, what kind of orders we're getting. So this is just of the post forms for which we were able to identify the orders. You can see 80% of them, so this blue here is DNR in Section A. So 80% of the forms that we get are DNR, and then 20% are CPR. Of the DNR, of those that check DNR in Section A, the majority have got limited additional interventions. It's close between limited and comfort measures, and then very few of them checked full treatment. So full treatment, it seems a little bit funny, and that's probably why it's so rare. It's not technically contradictory according to our policy, so you could say, I want full treatment, everything done, as long as I don't stop my heart and my lungs at the same time. If you stop breathing and your heart stops beating at the same time, then that person would not want CPR at that point. CPR, the only directive you're allowed to place is full treatment. So you can see here in the chart we've got 0.5% choose CPR and comfort measures, and then 3.5% have chosen CPR with limited additional interventions, and those are both contradictory directives. So we can't put those in the registry. They'll get a letter. A lot of times, sometimes we'll get a new provider who's excited about POST, and we'll get a slew of forms, CPR, limited additional interventions. We'll contact that provider, have a conversation, and usually it's a little bit more education. They hadn't quite thought about those orders being contradictory yet, and then they'll fix those post forms. They'll do new ones, and from then on we see directives that aren't contradictory. But those forms still stay in this stat, so since we got those forms, they're still here. So a lot of these contradictory directives have been fixed, but they still show up.
Right. Hey, Evan, there are some questions that have come in. Can I ask you one of these? Do we track what regions in the state post forms are coming from?
Mm-hmm. So we can see the facility, and we can see like the patient's home address, and so we can see the region. I don't have a good feeling. I haven't looked at that data recently to see like if there are hot spots. I think there are hot spots around Charleston. I'm not sure how familiar you are with West Virginia. Around Morgantown and Charleston, the two major hospitals are in Morgantown and Charleston, so we're not surprised to see that. But it is neat. We've done studies where we do county by county data, and we see the number of deaths in that county versus the number of people who are in the registry, and we're able to identify counties where we've got high registry participation. In some counties, over 15% of all the deaths already had forms in the registry, and then there are some counties where it's less than 5%, and we need to do a little bit more work.
Right, and I know Oregon has done. Yeah.
Go ahead.
Go ahead, Courtney.
I was going to ask the next question. That was a good segue. Does the registry keep track of patient deaths and remove the information from the registry at that time, or keep it for research purposes?
Mm-hmm. So yeah, we do. We get a weekly upload from the Bureau for Vital Statistics with death records. So we were able to match those, and we archive them, so they're not deleted. They're taken away, so they're no longer made available to healthcare providers. But we still have all those records in there for research purposes. That way, if we get a lot of calls, someone will call and say, hey, my mother died and she was in the registry. They don't need to call us, but they do, and that way we can still look them up and let them know. And sometimes people do write on their living wills or something like that, maybe funeral arrangements, that they'd like to be cremated or something like that. It's not specifically a healthcare decision, but they'll write that on there, and then we'll still be able to provide those forms posthumously. Also, sometimes Adult Protective Services will call and look up, they've got a body that's unclaimed, and they'll call the registry to see if there are any forms that might identify a family member or a medical power of attorney or someone that would be willing to take that body. So those records for deceased patients are still valuable, and so we definitely don't get rid of them by any means. But we definitely get those death records, and I think it's important to get those cleaned up, especially if you're sending out letters like we are. The number of uncomfortable conversations we have with patients, we sent them a letter, they get a letter from mom, and mom just passed away, and a lot of times they might be upset by that, and so we try and send out as few of those letters as we can. All right, so there are a number of errors that we're seeing in post forms that are pretty common. The biggest error is that it's just not opted in. I don't think this is normally because they're opposed to having their form in the registry, but usually it's that they don't read the instructions, and so maybe they put a check mark or an X in the box instead of initialing it. A lot of those get fixed. We send out a letter with a little form they can fill out and initial a box on that letter, saying they want to be in the registry, and they mail it back to us. So that is one downside of having the opt-in system, is that sometimes if people forget to check that box, that can cause problems. 7.3% of the post forms that we get are unreadable. A lot of this is because people are submitting via fax. We're hoping with better integration of the computer systems to start getting submissions electronically through the Health Information Network, so they would be scans. Just the pink paper, it just doesn't go through a fax machine well. And if someone's new and they're not very good with the settings on their fax machine, it'll just come through solid black. We won't necessarily know where it came from, and so we get unreadable forms. Physician signature problems are 6% of post forms. But one thing to mention is these categories aren't mutually exclusive, so these percentages don't add up. You can have a physician signature problem and have the form not be opted in. So a physician signature problem is either the doctor didn't sign it or they didn't date it. All physician orders need to be dated in West Virginia. Or maybe they signed it and they dated it, but we weren't able to identify their license, so they didn't print their name or we didn't recognize the signature. We don't know who it is. We have to verify that it's a licensed physician. Actually, it doesn't even have to be a physician anymore. APRNs can now sign in West Virginia, and also physician's assistants. So it should say provider there. Or something else that happens is residents who aren't licensed yet. Students at the med school will sometimes sign, and so that's a physician signature problem. 5% of the time we're missing patient info, maybe a date of birth, social security number is missing, sometimes even a name isn't filled out. That's something that's usually pretty easy to fix. 3.3% we're just missing pages or parts of pages. They send the back but not the front, put it in upside down. Maybe it gets cut off halfway. A lot of times the top will get cut off. Just fax errors. We're hoping a lot of that will be solved when we move to electronic submission. Problems in Section A and B, so we discussed that already on the previous slide, the conflicting directives, or maybe Section A and B aren't filled out. That also happens. And then the good news is that patient signature problems aren't very common at all. So we see the patients or the medical power of attorney signing the forms. They usually do a pretty good job. Oh, just a word about APRNs completing post forms. They have been. So they've been authorized for a little over a year now to sign forms, and we're seeing an increasing number of forms come from APRNs, which is great. I think APRNs are more available to attend educational events. They just seem to be on the ball. And so we're really happy to see forms being signed by APRNs in increasing amounts. Sometimes up to 25% of our post forms are coming from APRNs. Peggy asked a question, how do you validate a form that is uploaded by an unknown source? Is it truly from the patient? So the source might be unknown. We don't validate it. So we don't necessarily know where it's coming from, but we would still check the form to make sure that it's got the patient's proper information on it, that all the signatures are filled out. You know, if it's an advance directive, it's got to be signed by 2 witnesses and notarized. So it's not necessarily just because it's sent from home and not from a healthcare provider that it wouldn't be valid. So, and because we're accepting forms like medical power of attorneys that you don't need a healthcare provider to fill out, you know, we get a lot of forms where we don't necessarily know where they came from. But as long as they're signed by 2 witnesses and notarized, as long as it's completed correctly, then it's valid.
So this is a table from the research that we've done looking at APRN completion of post forms compared to physicians, medical doctors, doctors of osteopathy, and I know this is a little bit of a busy slide, but what we learned from this is where are the nurse practitioners who are completing forms, how does their location or practice setting differ from physicians? And one of the interesting things we've learned is that a high percentage of the forms being completed by nurse practitioners are nurse practitioners who are either hospital-based on hospital-based palliative care teams or nurse practitioners with community palliative care programs, often affiliated with a hospice. So this has sort of been interesting in that that nurse practitioners are more likely to have been in be in an urban setting in Charleston or in Morgantown, whereas the physicians are also in an urban setting. The doctors of osteopathy are more in a rural setting. Interestingly enough, our nurse practitioners, because they're taking care of even a higher percentage of really seriously ill patients, 90% of their patients for whom they're completing post forms have a do not resuscitate order. It's less for the physicians and the osteopathic physicians. And also notice that the nurse practitioners have a higher percentage of post forms with comfort measures orders compared to the physicians and the osteopathic physicians, and also a higher percentage are practicing in hospitals compared to osteopathic physicians. We can see that the osteopathic physicians maybe are more often medical directors of nursing homes, and therefore a higher percentage of forms that are completed by osteopathic physicians are coming from nursing homes. This is an article, this is in press in the Journal of the American Association of Nurse Practitioners, which I'm told is a prestigious journal for nurse practitioners, but it really suggests that there may be a niche for nurse practitioners, at least those who are comfortable doing advanced care planning. They may be, certainly they're completing more post forms in West Virginia than nurse practitioners in primary care settings. And this just, raises some issues with regard to the future practice of advanced care planning in this country. We know that many physicians do not seem to be comfortable doing advanced care planning. Many nurse practitioners seem to be more comfortable doing it, and this may then become something that we'll see in the future as we're trying to improve our healthcare system and figure out how do we get all the things done that need to be done. How do we have the end-of-life care conversations that need to be done so that we can identify and respect patients' wishes? And certainly this suggests that maybe APRNs can play a greater role in that regard. Let's see, I'm looking at other questions. Okay. All right, somebody's just commenting with a audio problem. Evan, if you want to advance to the next slide, please.
So now that we've reviewed all the statistical things about the eDirective Registry and our program here in West Virginia, we can explain our strengths and challenges that we've experienced over the past 15 years that our program has been around. The way we keep our program strong and continual growth of the eDirective Registry is our strong relationship with our Healthcare Information Exchange in West Virginia, which is named the West Virginia Health Information Network. That is where our registry, where healthcare providers can access our registry data. And we've continued to have a strong relationship with the West Virginia HIN. We call it the WIN here in West Virginia. And when they get through improvements, so does the eDirective Registry. The eDirective Registry data is a huge part of the WIN, and they know that. So they always include us in all of their communication, and we just attended a users group meeting last week and got very positive feedback from around the state of eDirective registry users. I think another strength of our system is the 24-hour-a-day, 7-day-a-week direct access for healthcare providers to access any healthcare form regarding, advanced directives, medical orders. That is just convenience. In the middle of the night, there's no call system or anything like that. They just need to sign on to the WIN and see that document, and it's immediately at their fingertips, and then they can upload it into their own medical record. It's just a simple process. And then I think our continual education, not just our once-a-year workshop that we provide on advanced care planning and offer to any healthcare provider, on a daily basis we are always answering the phone and answering questions about the forms, about completing advanced directives, whether it be a patient or a healthcare provider calling into us. We are always there to provide that support. And then as you can see after today's presentation, we continually have that ongoing research where we're always looking at our numbers and the forms coming into the eDirective registry and trying to figure out how we can improve our process and how we can improve care in West Virginia in regards to advanced care planning. Now with that being said, we have had some challenges over the years. One of the big challenges that we've recognized more recently than not is the man-hours that go into putting the forms into our registry. Because we don't have an ePOLST system at this time or an electronic submission source, our back end, so the employees manually input the metadata into the eDirective registry. So like any of the demographic information, stuff like that that is written on the forms is manually input into the eDirective registry. So that has been a challenge just because it's man hours and that is money, which leads me into the next topic. Funding, of course, is a challenge of West Virginia's system. We've been fortunate enough to be funded by the State Department of Health and Human Resources since 2002. And that money has decreased over the years. And recently, in 2016, our funding was cut by 64%. So this year we are kind of working on as little as we can to continue the operations and continue to serve West Virginians and the positive services that we provide to them. So in 2017, we have had a transitional period where we have come up with a solution, and of course the eDirective registry has been down. That just hasn't been on us. It's been with improvements with the West Virginia Health Information Network too. As we were going through a transitional stage, so was the WIN. So that was kind of two negatives did not turn into a positive in that deal. So we are currently down for access to the registry, but access will be granted again here in the near future. So we have a question. How does the healthcare worker get a username? Oh, sorry. The question is, how does a healthcare worker get a username to the registry? They can contact the Center for End-of-Life Care, and we can start the process with the WIN. In the past, they've had to complete a few easy-to-fill-out pieces of paper, and then the WIN would get in touch with them with the username and password. And then another question was, can a patient get a login too? And no, only healthcare providers can access the eDirective registry at this time. So that is one thing that actually last week at the users group meeting was discussed in incorporating the registry information from the eDirective registry into patient records. Like WVU Medicine has a system called MyChart, and it's where patients can log in and see all their test results, their upcoming appointments, past appointments. And the lady who builds that MyChart system had talked to me and asked, could these advanced directives be linked in with the registry, or can this MyChart system be linked in with the registry and have an individual's documents on their MyChart? And I I think it's a great idea to where it's always there in front of the patient too in case they lose their paper form, and it would be linked with the eDirective registry. So that's work that we can work on in the future.
Mm-hmm. And signing up for access, the usernames and passwords, is done on a facility level. So the facility or the organization would sign up, and then they can create usernames and passwords for all the people at that facility. So it could be a single nursing home, or maybe a whole chain of nursing homes would complete paperwork, and then at that point, that whole chain of nursing homes can then assign usernames and passwords to all their employees. So it doesn't have to be every single individual that fills it out.
And then if I could just pick up on this last question about how can other states use West Virginia's history and successes to improve their own programs. First of all, I think the fact that we now have research from Oregon, from California, from Indiana, from West Virginia, so this is not just one state. There are multiple states now showing that use of the POLST program can result in end-of-life care outcomes that are consistent with patients' wishes, that are aligned with patients' wishes, is a really strong finding that because patients are clear that they don't want to die in the hospital, we can prevent unwanted hospitalizations at the end of life. We can increase referrals to hospice. So I think as people in other states talk about their POLST program and its potential to improve end-of-life care, these are some of the things that they can point to. Certainly the registry has been tremendously helpful to us in terms of knowing where forms are being completed, what types of errors there are with forms, who's completing the forms. We really can understand a lot more how advanced directives and POST forms and DNR cards are completed. I don't recommend that every state immediately go out and start a registry. You really need to have enough forms out there so that if you do start a registry, then when healthcare providers log into your registry, there will be enough information there so that they won't say, oh, well, I've gone into the registry a number of times, I've never found a form I was looking for, I'm going to forget that. We really, and Oregon taught us this lesson, you really want to have at least a critical mass of forms in your registry so that when healthcare providers go in, they find the form they're looking for and they'll return and look up other patients in the future. So I think these are three of the lessons that we've learned. Courtney, others you want to highlight?
I don't have anything to add. Thank you.
Yeah. Evan?
I agree that having the registry come after there's already an established culture of filling out these post forms is really helpful. I mean, they grow together, but you do need a critical mass just to get started. I think accepting more forms, more varieties of forms can be really helpful for getting that critical mass because you're just appealing to a wider slice of the population. Anybody can fill out a medical power of attorney, where the number of people you can get to a post form is just a lot smaller. If you're going the mandatory submission route, that can be a great method, but if you're not going to get your critical mass of forms through legislation, then just expanding the number of types of forms that you take can be really helpful.
Right, and I guess to close, we're very enthusiastic about the POLST program. We've seen it really makes a difference as a result of the quality improvement activities and the research that we've done. We appreciate the fact that more and different types of healthcare providers are now participating in our registry and on our POLST program. The APRNs have now been sending forms in since June of 2016, and we see that they're really making an impact. Starting in September of 2017, physician assistants can now send complete medical order forms and send them into the registry. So we're looking forward to see how that changes the dynamics of our end-of-life care system. And I would just encourage all of you that I think we're all on the right track. I think we're working with a system that will really get good results, improve patient care, and that's I think what we're all about. So we appreciate the fact that you've listened to our presentation today to learn, to hear the lessons that we've learned in West Virginia. We hope that you can use this information to improve end-of-life care for patients in your location. So thank you very much.
Yes, thank you.
Great. Well, this is Hannah. Thank you so much for presenters for doing this today. It was a pleasure to host this webinar for you. Just really appreciate the conversation, the presentation today. So thank you. And I believe that's a wrap. If you have any questions, please reach out. And otherwise, have a wonderful afternoon. Take care.